Welcome to another Six Patterns video. My name is Max.
I'm Kevin.
And this is one of our series of the top 25 pearls of pulmonary pathology. We have broken this down into 25 specific pearls that you can take with you and incorporate into your practice. And each of those 25 are broken up into 6 main topics. And this is the first topic for the overall topic number 5. And this has to do with the approach to non-adenocarcinoma thoracic neoplasms.
Right.
We did a whole session on adenocarcinoma. A whole topic was devoted to adenocarcinoma because we know that's the one that causes the most headache and challenge on a daily basis. But these cases also can come across the desk and cause a lot of difficulty as well. So we've got a needle core biopsy here.
Right. From
an older male. 94-year-old male. And he presents with recurrent pleural effusions.
Right.
And I think he has some imaging studies, right? He has multiple pleural-based mass lesions.
And unilateral, which is kind of a key thing.
Unilateral pleural-based mass lesions, old male.
Yeah. So think about that for a second. Unilateral multiple nodular lesions, pleural-based. Okay, good. So other pertinent pieces in that context are he has no history of asbestos exposure.
That's a useful bit of information.
Maybe. Or maybe not.
Or maybe not.
You know, they only found out Steve McQueen had asbestos exposure because after he was diagnosed with mesothelioma, right, they went back and they grilled him on everything he had done in his youth. Yeah, because the lag period is 25 to 35 years. So you got to go way back to figure out when you're exposed. And it can be a minimal exposure, which is a little scary.
That's why we've gotten rid of asbestos.
Yeah. Or are still trying to.
Hopefully.
Yeah. That sandbox in your backyard is probably still a problem. Yeah. Okay, so a needle core biopsy was done.
Transthoracic. Pleural-based mass lesions.
Yep. Cool. So
and we've talked about this, I think, but needle core is a great specimen to get in pulmonary pathology because we're always complaining you need radiologic and pathologic and clinical correlation. But with a needle core biopsy, you have most of the information you need.
Because they only put needles in the chest for nodular disease.
When there's a nodule. So we have to make sure they biopsied something that would look like a nodule radiographically, and then we can make our diagnosis.
Right.
And I think certainly they've biopsied something that would look like a nodule.
Yep.
Right?
Yep.
This is not normal lung. This is not normal chest wall soft tissue, although there's a little bit of adipose tissue here.
Yeah, wow.
But we've got this robust proliferation.
A cellular process that's not quite blue, is it?
An
it's
epithelioid.
Kind of a pink epithelioid, yeah.
It's kind of pink and epithelioid. These cells are nice and plump. This almost looks like a fibrovascular core, almost.
Yeah.
And we've got these plump epithelioid cells that are kind of monotonous. They have a little pinpoint nucleolus. They're discohesive.
Not like frankly malignant.
Yeah, at least not here. Not 100% malignant. Here's some more of these fibrovascular cores. Now, I would say that from an architectural perspective, this is getting to be pretty complex in the way this papillary structure is branching.
Right. Redundant growth.
Redundant papillary growth.
Huh. Interesting. So reasonably bland for a cellular process. Some fibrovascular core suggesting a vague papillary growth pattern.
Here's some interesting stroma here. We've got some interesting stroma that has a lot of edema, and here's a few cells percolating underneath within the stroma. I don't know, I'm getting pretty concerned about this proliferation here.
Yeah.
And maybe some areas of more significant atypia too.
Right. But if you were going to grade this, let's say I told you this is malignant, would you grade it as a high-grade or a low-grade malignancy based on the morphology?
Based on the morphology, more of a low-grade malignancy. What do you think about this area right
That looks like invasive disease.
This looks like infiltrative disease of these relatively low-grade cells.
Yeah.
So, I don't know about you, but I'm ready to make a diagnosis of a malignant epithelioid neoplasm.
So the differential diagnosis here would be primary or metastatic carcinoma.
Yep.
And when we say primary, and we talked about the pleura, it wouldn't be a carcinoma, then it would be a mesothelioma, right? Because the mesothelial epithelium of the pleura forms a malignant tumor called mesothelioma instead of adenocarcinoma.
Right. Although adenocarcinoma of the lung primary involving the pleural surface is relatively common.
And maybe more common than actually mesothelioma epidemiologically.
I think is much more common than mesothelioma epidemiologically, by far and away.
So don't jump on mesothelioma if you think you have one, right?
Exactly.
First, really shake the tree hard to make sure that it holds, because once you make a diagnosis of mesothelioma, you open up Pandora's box for a bunch of reasons, which we may get to, or we may have to do another video at some point. But what are you going to do? How are you going to make that diagnosis, Max?
Well, so to me, once we've gotten to features of malignancy, and I think the infiltration of those few glands are definitive features of malignancy, the cytology is low grade, but I'm quite concerned it's malignant as well. Once we're at malignancy, really our only job left is to distinguish that these are mesothelial cells and not carcinomatous cells.
Epithelium, right.
Epithelial cells.
Wow, so we've got to do some stains. So do you have a preferred approach?
So I have a standard panel that I typically get, but I think the experts will say that you should have at least 2 stains that favor mesothelioma and 2 stains that favor adenocarcinoma.
Sort of targeted on, right? So 2 that target rather than favor, right? That because obviously they're not all going to be positive, right?
Right.
So your target should include a couple of stains that would support a diagnosis of mesothelioma and a couple that would support a diagnosis of adenocarcinoma, and hopefully not much overlap between them.
So staining supporting mesothelioma, calretinin, D240, WT1, CK56.
Yeah, that's 4.
That's 4.
So we put those down on the sheet.
So we've got those on the sheet. We'll get those. And then how about stains favoring adenocarcinoma of the lung? TTF1.
TTF1 is a nice, robust stain. You got nice TTF on this, you're done. It's an adenocarcinoma.
MOC31.
Yeah.
BREP4.
Yeah. I like CEA, but it has to be polyclonal.
CEA.
Don't do monoclonal. Yep. None of the tumors seem to stain with monoclonal CEA.
And polyclonal CEA. So I think with that panel, you could look at the results of that panel and feel pretty good about what the diagnosis is. So in this particular case, this was positive for calretinin, strong.
And where was the staining?
Nuclear and cytoplasmic.
That's important, because that's a specific staining pattern.
Yep. It was positive for D240, membrane.
Wow, fried egg.
Fried egg.
Yep.
Yep, just this nice, strong membranous staining D240. It was positive for WT1, nuclear.
Wow. So now we have 3 different staining patterns.
3 stains so far.
Within 4 antibodies.
And cytokeratin 5-6, strongly positive.
Cytoplasmic.
Cytoplasmic.
Nice. We've nailed them all.
Now, on the adeno side, negative for TTF1, negative for CEA polyclonal, negative for MOC31, and negative for BREP4.
Great.
So, we've got everything on this case.
Right.
We've got a clinical history in older male. Mesothelioma happens in older patients and typically in male patients. We have classic radiographic features. Multiple pleural-based nodularity with recurrent pleural effusions. We have classic histology of epithelioid mesothelioma, and we have a perfect immunohistochemical staining pattern.
We're done.
We're done. So this brings up the pearl. And the pearl is the diagnosis of mesothelioma should be easy.
Meaning if you follow the rules we just gave you, you should come to the right diagnosis 98% of the time?
98% of the time.
And if you're not coming to the right diagnosis, if you cannot make a definitive diagnosis, you've got to stop and ask yourself, something's wrong.
Yeah.
What is it?
And at that point, you need to back away from the malignant diagnosis.
Or consider another possible mimicker of not adeno, not meso, such as one you like, vascular tumors.
Oh, yes, vascular tumors.
So
pitfall, angiosarcomas.
Epithelial angiosarcoma.
Yeah.
Now, most of you are familiar with angiosarcomas other places, and you think, oh my gosh, those tend to be really bad looking cytologically. But some of them aren't. Some of them can mimic, like the epithelioid angiosarcoma and epithelioid hemangioendothelioma can be reasonably bland.
Right. So other things to consider, but the pearl here is the diagnosis of malignant mesothelioma should be easy.
Right.
And we often get asked, I want you to give an hour-long talk on the challenging cases in diagnosing mesothelioma. And I say,
That's not an hour talk.
It's kind of difficult to do because if you don't have everything perfect, at least in North America, you shouldn't diagnose mesothelioma.
Right.
You should take a step back and say, atypical epithelioid proliferation, suspicious for mesothelioma, or suspicious for adenocarcinoma.
Right.
But this is really an area where it's okay to take that step back and say it's atypical.
Well, I would say especially if your epithelial markers, particularly adenocarcinoma markers, are negative and you're struggling with a diagnosis of mesothelioma. Remember, mesothelioma is a universally fatal disease that doesn't have current treatment, successful treatment.
Right.
So if the patient does have the mesothelioma and you don't line up the stains correctly, or they're not lining up,
right,
why would you want to be the first one to diagnose that with not substantial evidence?
Right.
The patient's disease will continue to progress, and the least of his or her problems will be that they have to rebiopsy at some future date.
Right. So the fortunate aspect here is that most cases actually that come in are straightforward like this. So the diagnosis of meso should be easy, and most often it is. And when it's not, it's okay to take a step back and call it atypical. Think about some of the other possibilities.
And we haven't even talked about sarcomatoid mesothelioma, but we will at some point.
That's a whole nother story.
Because that can be a challenging diagnosis.
Right. But if you're having trouble with it,
send it to Max.
And I'll call it atypical.
Okay. Thanks, Max.
Yep.
I think we covered everything.
Don't forget to like and comment below. Thank you very much.